Hello everyone. I'm Swati Sharma. I'm one of the doctor working at Nottingham University Hospital, and this work is done by our team with Ishan Vijayvardhana, Dr. Shilpati, who is our consultant gynecologist and head of department, and Takwa Further, who is a specialty trainee with us. Our title of our study is the diagnostic accuracy of HSG versus laparoscopy in assessing bilateral tubal blockage in subfertile women. Why did we do it in the first place? Because during COVID times, we all know that the surgery was very hard to get to patients to theatre, and the patients who were taking priority were mostly oncology patients, and we did not have many theatre sessions to um, uh, uh, to take the patients to theatre for a laparoscopic lapidary test. And we know the fertility is age limiting, and hence the question became how much we can rely on HSG and how much HSG is important as a screening tool. So, coming to this question, what is HSG? We all know that it is a well established diagnostic method in the evaluation of female infertility, and which has been a part of our infertility investigation for many, many, many years. It is an X ray test where a contrast dye is gently passed through the cervix to outline the uterus and fallopian tubes, showing their shapes and whether the tubes are open or closed. And we can see in the picture that there is the dye has filled in the tubes and there is bilateral spill. So we mention it as bilateral fill and spill that noticed on the HSG. And of course, the NICE guidelines has recommended as a first-line investigation for women with high risk factors such as pelvic inflammatory disease, endometriosis, or prior pelvic surgery. What is already known? We know that the tubal factor infertility comprises one third of female fertility, and hence it is important to know to rule out this cause of infertility. When the women come in our fertility clinic after taking history examination and doing basic investigations like blood test for ovarian reserve test, we go through the history and see if they need any they need a test for a tubal patency test, which most of the patient do, unless someone has really poor ovarian reserve and going for some IVF treatment directly or male factor fertility. After that, we consent the woman for the HS. So HSG is our first line screening test in our unit, and we bring the patient for our HSG screening test. And following the results, we decide whether they need the laparoscopy um, or other treatment, depending on the results of the HSC test. The problem with HSG is that it is very very highly operator dependent, and the quality it all depend on the quality of the equipment used, including imaging resolution, type of contrast medium, and also the person who is doing it, if that is an experienced person or a new person. There are several patient-specific factors: tubular spasm, prior pelvic infections, surgery, and anatomical distortion. Sometimes can make the interpretation of the results very difficult. Also, this test is could be uncomfortable to patient, causing a lot of discomfort, especially if done just before and after the menstruation, and hence can lead to the diagnostic problems in the interpretation of the results. Coming to the next slide, despite this limitation, HSG continues to serve as a first line investigation in infertility. And I think it's mainly because it's minimally invasive. We can easily do it in an outpatient setup, and it's very easily trainable. So we can make the staff members trained to do this investigation, and hence it is one of the most common investigations done for the tubal patency in the country. So the aim of our study is to evaluate the diagnostic accuracy of HSC compared with the laparoscopy in detecting bilateral tubal blockage in a large UK fertility cohort. In our unit, we have a very mixed cohort of people and hence represent uh, like all the ethnicity, as we will be coming to the results as well. And hence it is important to interpret this finding as a global results. So materials and methods. We reviewed 1,105 women aged 18 to 45 years who underwent HSG at the Nottingham University Hospital between 2017 and 2022. Important thing to note that this is the main time when the COVID actually happened, and hence all of these patients who had blocked SSG or inconclusive HSG had to wait for a couple of years to actually have their laparoscopy done, and hence our cohort for initial SSG was from this year. Our exclusion criteria included the BMI of more than 35 kilogram per meter square, but that is the exclusion criteria for any ART treatment in UK. Or if we don't have the complete records, or a recent pelvic inflammatory disease, or a contrast allergy, or uncertain pregnancy status. The HSC results in our unit were classified as bilateral blockers, unilateral blockers, or both tubes patent. Sometimes they're classified as inconclusive if we can't categorize them in any of these category. The laparoscopy with dye testing was used as a comparator when it's been done for them. So this is a lap and dye. That's how it will look when the dye will come through the normal tube, and we can see the spill in the pelvis. So the results, among the 1,105 women, the average age of women in our study was 32.8 years, ranging from 21 to 45 years. And among 1,105 women, we noticed 22 women to have bilateral occlusion, 113 to have unilateral occlusion, and 970 women had bilateral patent tubes. And that is a very big number to know, and to acknowledge that 970 women did not need to go through invasive laparoscopic procedures because HSG easily ruled out the patency in these set of women, and hence it is important to acknowledge as a first line screening test. The diagnostic accuracy, when we did the laparoscopy for these women, so for the HSC who has shown bilateral occlusion, out of 22 women, there were 8 women who had bilateral occlusion in the laparoscopy, and there were 5 who did not have any bilateral occlusion. And the HSG showing not bilateral occlusion, either they have unilateral occlusion or inconclusive test. The laparoscopy actually showed bilateral occlusion in 5 of those women, and no bilateral occlusion in 29 women. Also, it's one thing important to note that the time gap between the SSG and the laparoscopy here resides from 2 years to 3 years. So even if it was a unilateral occlusion in HSG, sometimes can develop as a bilateral occlusion later on if there is an infection, ongoing infection at that point in time. However, because it's just an assumption, we cannot be sure about this finding. And so how we categorize and what we say, what true positives are, what false positives are. So we have given the definition, and the true positives are women who HSC showed bilateral blockage and laparoscopy confirmed bilateral blockage, and false positive are HSC showed bilateral blockage but laparoscopic found either unilateral or completely normal tubes. We calculated the sensitivity and specificity based on our results, and it came out to be 61.5% and a specificity of 85.3%. And here we can see all those screening tests, but it's not a very sensitive test, and it is only screening 61.5% of the women. However, it is very, very specific test. So if it has said like they are bilaterally patent, which then we can easily avoid the laparoscopy in those women, and that's the women I think we need to acknowledge, that 970 women that did not need the invasive procedure following the HSC test and went ahead with the IUI or ovulation induction or the ART procedure they needed. So in our study, HSG demonstrated a sensitivity of 61.5%, as I just mentioned. Um, uh, and the HSG, so what that actually means that HSG correctly identified more than 8 out of 10 true negatives, but it missed nearly 4 out of 10 true positives, which may be attributed to factors such as tubal spasm or technical limitation during the procedure. The positive predictive value was 72.7%, and the negative predictive value of 78.8%, which highlights that in approximately 8 out of 10 cases where at least one tube was thought to be patent on HSG, this was confirmed laparoscopically. The similar findings were there in the older in the other studies, um, which the sensitivity and specificity range from actually 65% to 90% in few studies. We have noticed some findings which were similar to our inclusion exclusion criteria, which show similar sensitivity of 75% and the specificity of 95.2%. Um, when HSG indicated bilateral tubal occlusion, subsequent laparoscopy revealed that nearly 27.5% of these women actually had at least one patent tube, and hence it is important to confirm it laparoscopically before sending them or advising them IVF. Of course, there's an option, but that's not the only option for those women if the HSG has shows bilateral tubal occlusion. The findings supported HSU's utility as a highly specific, minimal invasive screening tool, effectively reducing the need for laparoscopy during COVID-19. And we have recommended a reaudit in 2 years plan, because now we know there is no delay between the HSG and the laparoscopy, and might provide us with different values in the reaudit. So, in conclusion, it's a large cohort of 1,105 women. It's demonstrated HSC demonstrated bilateral patency in 970 women, avoiding laparoscopy in first instance, while highly specific moderate sensitivity supports its role as an initial screening tool. And if used judiciously, the results HSC and laparoscopy are complementary, optimizing diagnostic accuracy and guiding individualized infertility management. Hence, it still have a good value as a screening tool in the current scenario as well. Um, Thank you so much.